Hello, my name is Marvin Malik. I'm the course director of the Northern New England PNHP Health Policy Internship Program. And tonight's lecture is on the Medicaid program, history and current characteristics. So without further ado, let's move ahead. Medicaid was part of the Great Society legislation signed into law by Lyndon Johnson in 1965. It after 2 decades of great increases in work-related coverage of healthcare by unionized workers and many non-unionized workers, the U.S. healthcare system in the 1960s was left with fair number of workers under age 65 with coverage, but the elderly and the poor and disabled without coverage. So in 1965, two pieces of legislation were signed into law. One was the Medicare program, mostly designed to cover the elderly and also cover some disabled people. And then the Medicaid program, which would cover the poor with disability being another uh, qualifying uh, uh, criterion. So it would cover the poor, the disabled, and those working low-wage jobs in which the employer was unable to provide health coverage. So the funding it's jointly funded by state and federal governments, and a matching formula is used in which the federal government matches whatever the state spends. And this matching formula is determined by uh, the mean income or poverty level and income level of each individual state. So it's administered by the states, jointly funded by state and federal governments. The federal government matches states' spending for enrollees and qualifying services without limits. So there's sort of an incentive to spend more rather than less. And some of the criteria to receive that funding, states had to cover hospital, physician, and nursing home services with particularly generous coverage for uh, pregnancy and childhood. And here's a map that uh, points out that states with lower per capita income have a higher federal matching rate. So in other words, the wealthier states like Virginia, Connecticut, New York, um, California, they get only 50% match. The federal government matches dollar for dollar. At the other extreme are many of the poor southern states and Kentucky and West Virginia and New Mexico, and those states get between 70 and 78% of their um, funding. In other words, they pay 22%, the federal government pays 78%. So they're getting a lot more money from the federal government per dollar they spend. Administration of the program is at the state level with a set of rules and criteria built into the legislation. However, the state governments do have latitude about how generous to make their programs. Also worthy of notice that the majority of states actually contract out program administration to private insurance companies. More on that later. Some eligibility criteria are mandatory. Medicaid is only available to legal U.S. residents. Eligibility is tied to income and wealth. If you own stock from the stock market, you're you're not going to get coverage if it's any meaningful amount of wealth accumulated. But I believe you are allowed to have a car and a house as long as it's not too valuable. And then disability status is also a major factor in determining whether Medicaid will provide coverage. Noteworthy is a very comprehensive benefit package. Hospital care, doctor care, prescriptions, physical therapy, um, a lot of services for children who are learning disabled. So even some programs within schools are covered through Medicaid for kids with learning disabilities. And generally, the benefit package does not entail deductibles or co-payments. And often includes some social supports, such as transportation to get to medical appointments. And for children, dental care is part of what's covered. Those are mandatory benefits. Other benefits are optional. Their states can opt out of providing them or set stringent eligibility criteria. So a major part of the Obamacare legislation was to expand coverage of childless adults. It originally was 100% of poverty level. If you were at all above poverty level wages, you couldn't get covered as a childless adult. The Obamacare legislation raised that to 130%, 138%. So in other words, 38% above the cutoff for what's considered poverty. And that was, as noted here, that's an optional. The states did not have to provide that. And 10 of them have not provided it. And that's a special benefit because unlike the remainder of the Medicaid program, for the first 3 years, that Obamacare expansion of Medicaid was going to be 100% covered by the federal government rather than at whatever the state's matching rate was. And subsequently, it would be 90% paid by the federal government. So it was a lot more generous assistance to the states that were willing to expand their Medicaid program. And in 40 out of 50 states, they did expand. And in the 10 other states, and mostly in the South, they never did expand their Medicaid programs to cover very poor childless adults who were just above poverty level. An optional benefit is dental care for adults. And for children, there's a wide range of options the state has. They at least have to cover up to 141% of the poverty level for children, but they're allowed to go all the way up to 380% of the federal poverty level. So there, the states have a lot of latitude. And then there's eligibility for kids and parents for the child's first year of life, up to 138% of the federal poverty level. And then, as I said, 40 out of 50 states are shoving Medicaid patients into managed care plans. So Medicaid eligibility for kids, as I said, it can go all the way up to 380% of poverty. And here's a map that shows which states have allowed coverage for kids a good deal above poverty level. And the states in the black have the most generous programs. So that includes Vermont, New York, West Virginia, Kentucky, Louisiana, California, New Mexico. At the other extreme are states where they're much less generous in terms of coverage for impoverished children, with New Hampshire and most of the plain states not providing very generous coverage. Now, here's a map that shows the proportion of the population in each state that's below 200% of the federal poverty level. And so, as you can see, a lot of the eastern seaboard states are wealthier and have a lower percentage of their population in those poor categories. And then the states in the South, many states in the South have much higher proportions of their population below the 200% of the federal poverty level. And then, and here is the percentage of the population covered through the Medicaid program. And you can see that there's a high correlation between poverty and, what the proportion of the population that's covered, but it's not exactly the same. For example, New, California has a substantial portion of its population covered through the Medicaid program, but only a smaller portion of their population under 200% of federal poverty level. Texas has a large portion of its population below 200% of federal poverty level, but fewer of their population is covered that way. So this is based on the generosity of the individual state governments. So to explore this a little further, we compared Mississippi to Vermont. And what you can see is that the pie charts at the top here are showing that only 26% of Vermont's population is less than 200% of poverty level. And a similar percentage of Vermont's population is covered through the Medicaid program. It's about a quarter. On the other hand, in Mississippi, on the right, a quarter of their population is covered through Medicaid or the child health program. It's an expansion of Medicaid. But 41% of their population is low income. So Mississippi is a lot less generous to its population. And upper right corner is the uninsured rate. And in Vermont, it's only about 7% or so, whereas in Mississippi, it's between 15 and 20%. And that's one of the reasons why is that they're less generous in what portion of the poor population is covered. They've allowed onto their Medicaid program. So Vermont is a Medicaid expansion state. Mississippi is not. And eligibility levels for children in Vermont are 317% of poverty, whereas in Mississippi, it's only 214%. And Vermont allows a higher portion of pregnant women into the program, higher percentage of parents in terms of their eligibility level as a percentage of poverty level. And childless adults, Vermont allows up to 138% of poverty. That's part of the Medicaid expansion under Obamacare. But in Mississippi, that's 0%. And seniors and people with disabilities is covered 74% in both states. So Vermont has a very small, on the lower right, pie chart shows that only 5% of non-elderly Medicaid enrollees are people of color, whereas in Mississippi, it's much, much higher. And then in the lower right corner, far all the way to the right bottom, 73% of adults in Vermont who are on Medicaid are working, but they're just not earning enough money to get terribly high above poverty level. but Vermont has extended its program to cover people who have modest earnings. Mississippi is much less generous in that regard. Only 47% of Medicaid recipients in Mississippi are working. So let me continue. More comparison of the two states. Vermont is considered relatively wealthy compared to other states. So Vermont pays 44 cents for out of every dollar of Medicaid spending. The other 56 cents comes from the federal government. Comparing that on the right to Mississippi, the state only has to pay 22 cents for every dollar it spends because they're getting 78 cents from the federal government. In the upper right, that's just the Obamacare program, where the state would only have to pay 10%, but in Mississippi, it's not included in their program anyway because they never adopted to accept Obamacare. In Vermont, 40% of births were covered through Medicaid. In Mississippi, that's 60%. That's because a much higher portion of women giving birth in Vermont are not in poverty. And Vermont has adopted the 12-month postpartum coverage extension, which has not been adopted in Mississippi. And Vermont actually does provide great coverage for children, so that's probably not accurate or old. Mississippi did expand for their children. Let's see, move on here. So on the lower right, you can see that for people on Medicaid, they have an 85% chance of having had a doctor visit in the last year. For private insurance, it's 81%. And then for the uninsured, only 53% of the uninsured have had a doctor visit in the last year. You can also see that individuals without insurance are a lot less likely to have delayed care due to cost. So Medicaid enrollment expanded rapidly, really starting in 1987, but especially after we got into the 2000s. Part of the reason is income inequality, that a larger proportion of the population is poor, then the middle class is shrinking. And so more people are qualifying for that reason. Also, around the late 1990s, the Clinton administration created a generous benefit for children called the Child Health Insurance Program, CHIP. And that allowed a lot more children to become eligible. Then after the year 2008, you had the Great Economic Recession, which added even more poor people to the U.S. population. And then in 2013-14, you start to implement the Medicaid expansion under Obamacare, which allowed a lot more people in. So Medicaid has become an extremely important program in terms of population coverage, and it's now covering approximately a quarter of the U.S. population. Now, in terms of reimbursements to hospitals and doctors, I said earlier that this varies state to state since the program is administered at the state level, but really the range is from low reimbursement rates to very low. Both physicians and hospitals tend to lose money for many types of care or diagnoses when they treat patients insured through the Medicaid program. And providers of care are pretty aware of this. Nurses and doctors, they all know that they're not being paid well for Medicaid patients. And consequently, additionally, many nurses and doctors regard patients insured through the Medicaid program as welfare patients. And in some ways that makes sense because qualifying for Medicaid is due to poverty, as being poor. So it's sort of a welfare expansion to provide medical coverage for people who are poor. And but however, many doctors and nurses may not treat Medicaid patients as well as uh, people insured in other ways. There's also a population of people insured through the Medicaid program, usually very poorly educated, who may overuse healthcare services due to just poor educational level and not understanding what issues are and are not important or to be seen urgently, for example, in emergency rooms. And the poor reimbursement for providers has not been impacted very much by the rise of Medicaid managed care. They reimburse poorly too. So the groups of Americans served are low-income families, pregnant women, children, individuals with disabilities like kids with autism or cerebral palsy. HIV was many patients affected with HIV were insured through Medicaid. And then it's the big provider for people with chronic mental illness, schizophrenia, and other major mental health, chronic mental health issues. And then many elderly people who are poor are covered through Medicaid. In this population of what are called dual eligible, who qualify for both Medicare and Medicaid, they are the sickest and most expensive patients generally because they're elderly, meaning likely to have more health problems, poor, and often with poor educational levels. So often they have difficulty contending with major illness. And a lot of people in nursing homes are covered through Medicaid after their Medicare benefit is used up for which happens pretty quickly for chronic care. So health insurance coverage now for well over 1 in 5 Americans. 10 million Medicare beneficiaries have Medicaid coverage. More than 50% of long-term care is financed through the Medicaid program. Support for the healthcare system and the safety net because it gets some money to hospitals who take care of the sickest people, and it gives some flexibility to states to address health challenges. So note that non-elderly adults, in other words, age 18 through 65, and children with disabilities are only 14%, 1 in 7 of Medicaid enrollees, but 40% of spending. They're the most expensive to take care of. So on the other hand, on the right side here, if you look at Medicaid spending per enrollee, it's far higher for children and non-elderly adults with disabilities than for those without. So for example, children who are not disabled cost the Medicaid program on average $2,619 a year, whereas kids with disabilities, it's $18,700. So it's a lot more. So you can see that it's a very important program for the disabled, and much of the cost of Medicaid the spending in Medicaid goes to people with disabilities of all ages. So Medicaid financing, almost all states have balanced budget requirements, so the state cannot spend more than what it's collected in revenue. And it's counter-cyclical, meaning during recessions, when income tax and sales tax revenue will tend to drop considerably, that's when more people are unemployed, more people are poor, and there's going to be more people qualifying for Medicaid at the very time when states have lower revenue to pay. And since states continue to have to balance their budgets, State expenditures are come under a lot of stress during downturns in the economic cycle. The states often at that point start paying their clinicians even worse, or even cutting away services, some types of optional services like dental care for adults. And as they cut reimbursements, more of the physicians and other clinicians may refuse to treat Medicaid patients. So overall, nationally, 70% of physicians accept new patients who are insured through the Medicaid program. And I just want you to look carefully at this map. And this map turns out pretty much the same each year. And if you sort of go through the states where, where the highest percentage of physicians do treat new Medicaid patients, you'll see that these are rural states, small states. Often these states will have one major medical school, and medical schools usually will provide care to state patients insured through Medicaid. And then the rest of the state, for many of these small states, it's the university hospital that will take the complex patients, often who are poor, and they'll take people who are poor, regardless of how sick they are, actually. And then in all the rural areas, the doctors will tend to treat everybody. In other words, if you're 200 miles from the next doctor, you're going to tend to just treat everybody in town and not discriminate so much. So you can see that that works out that way, that the less populated states in northern New England have almost all the doctors except Medicaid patients. Same thing for the upper Midwest and the Plains. And then for uh, more urban states with big cities, you'll see that doctors in suburbs and at fancy private hospitals may refuse to treat patients insured through Medicaid. And so that's one of the features of the Medicaid program is that the many of the wealthiest physicians will refuse to care for Medicaid patients because they don't want to deal with the paperwork and the low reimbursement rates. So this is something else you'll see. It's an urban suburban phenomenon mostly. And in those urban areas, therefore, you end up with clinics, community health centers that will primarily treat poor people. And as we noted previously, many specialists won't see kids with Medicaid coverage. So on this graph, you're seeing that people with private insurance, almost all the specialists will see them, whereas what they're calling public insurance, which is basically Medicaid and Medicare, a lot of the specialists aren't willing to see patients insured through those programs, especially Medicaid. Um, However, if you do qualify for Medicaid, despite the fact that many physicians may not accept patients insured through Medicaid, um, it's a lot more likely you've had a doctor visit if you're in the Medicaid program as opposed to being uninsured. 5 times more likely, 80% more likely to be aware of having hypertension, and 70% more likely to have your hypertension well controlled. So Medicaid is helpful. Also, a randomized controlled trial uh, Oregon identified that people who had Medicaid coverage were about twice as likely to have had a mammogram, those who qualified for getting the test, about 40% more likely to get a pap smear. They're 50% more likely to have their depression acknowledged and treated. If they had diabetes, they're 80% more likely to be taking medication appropriately. And your people without Medicaid coverage were over 5 times more likely to have catastrophic medical costs. So, in general, Medicaid was enacted into law to the Democratic Party, and the Republican Party all along has been wanting to reduce payment in spending in the Medicaid program, and have proposed imposing copays, work requirements, more efforts for proof of citizenship or legal immigration status, and also block grant funding. Rather than matching every single dollar the states spend, the federal government said, well, we don't want to encourage you to spend so much money, so we'd rather just give you a fixed amount of money. And overall, there's been experimentation with all of those ideas, least so the co-payment idea, because when that's been tried, there's a whole lot of um, patients who are very poor are discouraged from getting care. Work requirements have been studied, um, and later on in this internship, we're going to discuss work requirements in greater depth. And also, this slide does not include the One Big Beautiful Bill, and in that session in the internship, we're going to discuss the Medicaid changes that legislation enacted, and a lot of the work requirement discussion will take place then. So, talk a little bit about the privatization of Medicaid now, otherwise known as Medicaid managed care. Starting in the mid-1990s, which was the era when managed care was greatly expanding, it was the big fad of the 90s. Most states began to contract out most or all of their programs to private insurance companies, otherwise known as managed care. This gave them budgetary predictability. That was a big draw. They thought they would save money. These managed care programs all said, oh, we're going to improve care coordination and quality. That was the allegation or the advertising. And there would be more flexible benefits, managing the network, whatever that means, and payment schemes that might involve disincentives to providers who ordered a lot of tests. So, for example, I was part of one of these between 1995 and 2000, where every time we ordered an X-ray or a specialist visit or our patients were hospitalized, we actually lost a little money, the way this financial scheme worked out. So here, this slide reflects the growth of Medicaid managed care enrollment in the US. And you can see that it's been now around 75% since 2015. And the heavy growth period was during the 1990s. So, and note that 2 states experimented with managed care organizations and then abandoned them, including Oklahoma and Connecticut. Oregon has one program managed by community doctors rather than insurance plans. And all 3 states have actually done better without the standard private insurance run Medicaid variant. So the question is, what happens to costs for the states? What happens to accountability for whatever the managed care company is doing? Does it actually help the state with healthcare costs? And what are the implications for access and quality of care for beneficiaries? Unfortunately, most of these are not well studied. Overall, there's evidence, especially from the Connecticut story, that Connecticut actually paid more when it had had hired, subcontracted to a private um, managed care organization. Then after it ended it, and it saved money by eliminating managed care. So it may be spending more money. Accountability is an issue. It's very difficult for the states to find out in detail what these companies are doing. So the question is access and quality of care for beneficiaries may likely is poorer with managed care. They're very profitable, uh, and the sickest people in Medicaid actually generate the most profit. Medicaid has subvariants, general assistance, assistance for families with dependent children, different varieties. As I said, dual eligibles, these are people who are also qualifying for Medicare. They're by far the most expensive. They're, generally over age 65 and disabled. Um, and the accounting is often pretty turbid with mixing their Medicaid data with commercial plan data. So very difficult for states to effectively regulate them or hold them accountable. And from the state's point of view, they become a kind of black box. We send them money and hope that our Medicaid patients are being treated appropriately. So in Hawaii, they converted from fee-for-service to a managed care in two steps, 1994 and 2009. It increased the administrative hassle, didn't save money. There was a big decline in physician participation in the Medicaid program, worsening access to care for the patients, and the increases in cost to the state were 3% greater than the national average for the first 14 years of this century. And the patients with mental illness did the worst. Half of the psychiatrists had dropped out within 4 years, and mental health related emergency department and hospital costs increased by 30%. So in Hawaii, it was a fairly big failure. I still don't think they've eliminated the program, though there's been a lot of discussion about that in Hawaii. So another issue is prior authorization. Managed care companies typically, every time a doctor orders an MRI or a visit to a fancy specialist, the insurance company will require the doctor to start to explain why they've ordered this test or this visit or treatment, and the denial rates are especially high in the Medicaid program. I just want to say that the rate of denial is not just affected by how many denials there are, but how many times they're by the denominator too, by how many are asking for. So, for example, in Medicare, they're now, from among the whole Medicare population, these Medicare Advantage companies have gone up to requesting around 55 million prior authorization requests, which is a huge hassle for doctors. And the fact that they're denying 7.4% rather than a higher percentage is partly reflected by how many they require in the first place. So the whole business is a hassle. And, where some sitting in a cubicle in a suburb of Dallas is talking to a doctor, that's the first thing. The person in Dallas has never seen the patient. They don't know the whole history. They haven't talked to the patient's other care providers. They don't know the social situation the patient's in. So it's, quite absurd for all this prior authorization business to be occurring. So anyway, there's also the issue of appointment availability for managed care patients who can't get appointment when they have referrals. And so there's a lot of waiting going on. A quarter of them got an appointment with a specialist within 2 weeks, but another quarter were above 2 weeks, but the other half, the referral couldn't happen either, mostly because the doctor wasn't taking any more patients in that plan, or they weren't participating in the first place, but they were still on the list. And that's called a ghost provider, where a patient makes a referral to a provider who's actually not in the network at all. So that's something else that goes on in this managed world of managed care. So Medicaid managed care is a major revenue source for insurers. They make a lot of money through it. And states implement controls on costs of pharmaceuticals. They can negotiate with pharmaceutical companies. And there's also primary care case management, where to pick out the most expensive patient in primary care providers' practice and sort of focus on them and try to keep in touch with them by phone frequently. And then I already talked about that. States have discretion to mandate enrollment or leave it voluntary. In most states, it's actually mandatory. For states that have managed care, usually make it mandatory. They're supposed to allow a choice of a couple different managed care companies. So you can see it's rising. And by 2021, 41 states used capitated managed care models to deliver services, meaning the providers don't get paid more if there's a lot of visits or a lot of specialty activity going on. So you can see that this capitated managed care is becoming the rule these days. And then in 40 managed care states, 6 firms cover just over, or for-profit firms in the Fortune 500 take care of over half the patients. Centene and WellCare and United Healthcare, these are some of the big ones, and then Anthem. So, and then the other half have local or regional managed care organizations. So in summary, Medicaid's a Great Society program from the 1960s designed to provide coverage for the poor and disabled. It's administered by states with matching funds and guidelines from the federal government. There's a lot of state-to-state variability and generosity of benefits. Providers are almost uniformly poorly reimbursed. Many refuse to care for Medicaid patients, and it's pretty heavily privatized at this point with Medicaid managed care. And as previously noted, a discussion of what the Big Beautiful Bill and Trump 2.0 have done to the Medicaid program will be covered in a subsequent talk. Anyway, thank you all for your attention, and I appreciate it greatly. So take care. Take care.